Welcome to the award-winning Women in Healthcare Leadership podcast series brought to you by Medscape Education. Our mission is to educate, advocate, and inspire women in healthcare to lift as they rise. Each episode brings you voices of leaders who are breaking barriers and leading the way in advancing women's health. Join our global community of listeners as we hear from her. Ready to be part of the movement? Let's dive in.
Welcome to Hear From Her, where we spotlight bold voices driving change in healthcare. In this episode of Women Leading the Change and Changing the Parkinson's Narrative, we're talking about long overdue shifts and how we understand, diagnose, and care for Parkinson's disease, especially among women. Today, we're going to explore the need for research, better clinician education, and early detection strategies. I'm pleased to have two wonderful guests here today with me who are leading the charge to make some of these changes. First, we have Dr. Padma Mahant with CND Life Sciences, Director of Medical Affairs. Welcome.
Thank you so much, Sarah. Hi, Indu.
And we have Dr. Indu Subramanian, a neurologist with UCLA. Welcome.
Thank you for having us.
So let's begin by getting to know a little bit more about your journeys, not just, your titles or roles, but what drove you to this work. Can you share a little bit about what led you to focus your career on movement disorders?
Yeah, so for me, I think going into medical school, I had this plan of going into pediatrics, and I got into my pediatrics rotation, and I realized I need to pivot. It's a completely different world being on the caring side of and the medical side of taking care of kids, and so I wasn't quite sure what I wanted to do, but I was open to other things, and I did my neurology rotation in medical school and absolutely loved it. The time that we were able to spend with patients, being able to sort of be their detective and helping them figure out what was going on, that was very interesting to me. So I decided to do a residency in neurology at the University of Rochester. And that is where I met some wonderful movement disorder specialists who would be my mentors. Rochester was the home of the Parkinson Study Group. And so they were just starting with a number of multi-center trials looking at therapies and surgeries for Parkinson's and really sort of revolutionized the ways that studies were done in Parkinson's. So Ira Schulzen, Roger Kurland, Carl Kieberts, Irene Richard were all my mentors, and Rochester was just a very collaborative, fun place to be and to work together, and to really focus on taking care of patients and moving the field forward. And these patients are just wonderful, and it was my pleasure to get to know them.
Yeah, and I guess from my perspective, I always thought the brain was cool. I have a neurologist as an uncle. I have a lot of folks in medicine in my family. My mom's a family doctor. I went to medical school in Canada, and I went to the University of Toronto for my training as in medical school. And at that time, many of the pioneering neurosurgeons and neurologists were just starting to do, different types of surgeries for Parkinson's as well. And I think Padma and I trained at the same time, and so we saw just a revolution in how people did. Also, the medications were being refined. And I think, through my training, I just really got a new sort of appreciation for living with a chronic neurodegenerative disease like Parkinson's and getting to know the families, getting to know the patients, understanding them sort of over sometimes decades, and really sort of becoming part of the community that really cares for this sort of patient population.
I'm curious, was there a moment or a turning point when you realized this is where I want to make a difference? And what did that look like for you?
I think for me, sort of the turning point that got me to where I am now, being involved in medical affairs for a life sciences company, was really, again, informed by my clinic and by patients in my clinic. So I found as a movement disorder specialist that patients sometimes would it would take several years for patients to find their way to me. They would have some misdiagnoses, multiple diagnostics and multiple medication trials, and really have lack of clarity on what their diagnosis was. And then, after few or several years, they would come to me, and by then their Parkinson's had really progressed. And to me, that seemed like a lost opportunity that perhaps if we were to, start treatment earlier, these patients would not progress as quickly. And we know from, original sort of staging studies that when levodopa came online as it became available for Parkinson's, that the progression really slowed. And so it's very clear that treatment does help to improve quality of life and slow progression significantly. So I really felt that having that a diagnostic tool would be helpful, and I wanted to be involved in that in terms of educating and getting involved in some of the research studies in terms of how can we use this? Can we move the needle and actually get to an even earlier diagnosis? So not only diagnosing patients at their first onset of motor symptoms, but we know that there's a significant prodromal state for these patients, potentially several years prior to developing motor symptoms. Patients may have REM behavior disorder, for example, or they may have hyposmia or constipation or depression, mood disorders. And we're actually finding, we just presented the sleep study, that we can, in patients who have just RBD and no motor symptoms, we can actually find the protein alpha synuclein, phosphorylated alpha synuclein is the detection that we're actually finding through the SIN1 test. And we're actually able to catch that in 75% of patients with RBD and no motor symptoms. So I really feel like this is an opportunity that we can, again, move the needle, get to a point of disease modification and maybe even prevention at some point.
I guess on my end, I think at some point I found that I think classic Western medicine really wasn't serving all my patients that well and wasn't serving me terribly well. So I became curious about other things. I started yoga practice and a mindfulness practice in my own life. Ended up getting trained to teach those things, and got quite interested in this whole universe of integrative medicine. So that's the sort of land between classic Western medicine and other sort of alternative practices around the world, health systems like Ayurveda and traditional Chinese medicine and other things. And really sort of started leaning into some of those things when I was seeing patients in the Parkinson's world, especially around non motor symptoms, mental health symptoms, other things that cause them distress, and even in the Parkinson's plus disorders and other things that we don't have very good treatments for at the moment in movement disorders. So I sort of became curious, started training, ever curious, and so I've done a number of trainings. And continue to sort of try to learn what we can take away from some of these other practices and bring to our patients. And I think we've sort of in a place now where, because of being able to think about earlier diagnosis, because of hopefully educating folks on who's not being served, who gets this disease. It's really not just images of older Caucasian men with motor disability that is Parkinson's. It's really this other sort of, many, many populations with many, many presentations and many, many age groups that are developing this disease. It's actually a disease that's actually much more common than we thought. It's doubled in the last 40 years, was slated to double in the next 20 years, and has already made that milestone. So we're seeing a lot more of this. And so I think we are really just in a place where we need to be much more proactive about diagnosing. And then once people have a sense that they have, trajectory that includes Parkinson's type symptoms, my hope is to really think about what are the wellness strategies, what are treatable lifestyle measures that we can start teaching people to live better every day. And so, putting themselves as the agent of their own change, helping people to recognize that they can be part of, their own health and wellness, and hopefully, developing those strategies early so we can prevent progression.
Wow. So this has really not been a linear path for either one of you. I think as you tell your stories, I'm hearing it takes a lot of courage to kind of step outside your comfort zone, explore new areas, like you said, challenge the standards of classic Western medicine, the importance of remaining curious and moving that needle to challenge the standards. So, I'd love to shift gears and talk a little bit more about how we can support the next generation who are just stepping out into this field. What advice do you have for the young professionals who are looking to make an impact like you all have?
I think collaboration is really key. Working within teams, and I will say that when I pivoted over to medical affairs, one of the first people I called was Indu to say, "Hey, I'm thinking about making this shift, and what do you think about this?" And I think having that network of folks that you really trust and that you respect in terms of their knowledge and their experience, I think is really important. I joined the company because it was a colleague of mine actually on the neuromuscular side who had founded the company and had been doing a lot of work on um, uh, cutaneous neurodiagnostics for some time on the neuromuscular side and then shifted over to movement disorders. And I found that fascinating. And I thought, if there's a way that I can help with my background, that's exactly what I wanted to do. And so having that network, I think, is huge. I think, as you mentioned, Sarah, the curiosity, I think, is very important as well, and staying motivated, being resilient, especially when, sort of the sands are shifting beneath our feet. And I think that resilience is really important and pivoting, learning to pivot and find, different funding sources and such, I think is really going to be crucial for this next generation. And I think also, just keeping the core of what you're doing in terms of keeping patients at the center of everything in terms of what you're doing, I think is so helpful to just know that, just to feel that everything sort of starts and ends with the patient in terms of your mission, your passion. Indu and I are both, proponents of wellness, and I think that shows in how we care for patients and what we recommend to patients, and the relationships that we develop with our patients. Having patients in our clinics that we've known, literally just last week, I had a patient say, "How long have I been seeing you?" And we figured out it was about 20 plus years. So it's pretty amazing to develop those sorts of relationships.
I think we all went into medicine to really, at our core, hopefully help make other people's lives better. And I think, in this ever rush time frame with, RVUs and billing and electronic health records and all the things that get in the way of, that patient interaction, I think that's really what fills my teacup time and time again is, helping a patient and hearing that they're doing better because of something that I was able to bring uniquely as a woman, perhaps who was able to slow down and take the time and connect that make them feel better, maybe leaning into their prayer, spirituality, dance or music or something else that may make them feel better. It may not just be a pill or a surgery. It might be something that is very unique to them. And I think, one of the things that I've also been struck by is, again, how much we can learn from our colleagues. So we have, relationships not just with neurologists, but a lot of the multidisciplinary team, physical therapists, psychologists, psychiatrists, anyone who touches our patient, can teach us something. And I think, I've been really spending a lot of time thinking about, I think just in the last few years since the pandemic, who's not being served and how to do that better. And women certainly are tremendously underserved. Women of color, people of color, people who are around the world globally who can't even access basic medications.
I think we're touching on some interesting topics in terms of, the importance of remaining resilient, leaning on your colleagues to ensure that we're continuing to listen to our patients, to have that voice to shorten their diagnostic and enhance their journey with conditions like Parkinson's. So I'd love to dig into that a little bit more and hear your take on what's really behind gaps in terms of delays in the diagnosis of Parkinson's, especially for women, and how we can go about closing some of those gaps. So while we know Parkinson's is more commonly diagnosed in men, we are seeing more data that's suggesting that women may be underdiagnosed or diagnosed later. What do you think contributes to this?
So we wrote a paper actually on gaps for care for women living with Parkinson's, and that was a paper that was inspired actually by a series of support groups that I ran during the pandemic. I really was worried about people disconnecting in the pandemic, and so I sat right here at my dining room table and actually interviewed a number of thought leaders, including patients themselves who are living with this condition globally. And upon talking to the women, they kept talking about how they had unique needs. they felt that their hormones were affecting their symptoms throughout various different life cycles. If they were menstruating still, that's the Parkinson's symptoms got worse when they were having the period or the week before their period. There wasn't great data on pregnancy and Parkinson's. There wasn't great data on the premenopausal and perimenopausal timeframe and postmenopausal timeframe and how menopause affected symptoms. So I think that was a pretty big gap that they identified. Upon hearing about their stories, many of them talked about how they were told for many years that they couldn't possibly have Parkinson's because they were young women. They didn't fit the image that people thought equals Parkinson's, and that is something that we have to really, I think, dispel the myths that only older Caucasian men with motor disability and wheelchairs are the image of who has Parkinson's. It's really affecting many women globally. Actually, in Asia, it's equal. So it's not that women are a rare, sort of population that has this. And there are many young women. Definition of early onset Parkinson's disease, or YOPD, young onset Parkinson's disease, is below the age of 50, and greater than 15 to 20% of people presenting with Parkinson's are in that age group. So it's definitely not the minority. Overall, I think it's still a very large population of folks that are having this disease at younger and younger ages, and certainly women are a big part of that. And when women are told that there's nothing wrong with them, that it's all in their head, that they're just having a stress reaction, or that they're just um, it's a mood, or that they might be depressed, and to go to a yoga class or to take an antidepressant. And then they learn, 5 years later, that a Parkinson's diagnosis was missed. It really sets them off in a very negative space to be able to interact with the healthcare system. There's a lot of mistrust, and then patients don't want to come back. And so these are stories that are not unique. We hear this time and time again, and I think Michael J. Fox did a good job of learn teaching people that young people can get Parkinson's. But we have to have images of younger women in these campaigns so that people know that this, people who look like Padma and I can get this and are living with this every day. So that is part of it, is that we have these images still taught in medical schools of motor disability in older Caucasian men. So we have to change that image. We also have to get the voices of women out. I think women tend to not complain, even when they're mistreated or have negative journeys, because they don't see other people that look like them. They often feel like they're a one-off story. And so when you get women together that start talking about their journeys, and they realize that it's actually not, the exception, is actually becomes the rule, that people's diagnoses were missed. Giving support to women is quite different than men. And also from a research and a research participation angle, there's really not very many women participating in research in general. And so getting women to understand that their voices matter is a huge part of this.
And that I'll just add that 5-year mark is really interesting because I have been doing a deep dive in our we had a survey that we put out to patients who had completed the diagnostic test for Parkinson's, the SIN1 test, to see sort of what were the symptoms that led to their testing, how long they had had their symptoms. And interestingly, twice as many women, percentage wise, were 5 years out from their motor symptom onset compared to men. So having to wait 5 years from the onset of motor symptoms to actually get a diagnosis or get to the point of a diagnosis that would further help them in their diagnostic journey is really, to me, was quite striking. And weakness was one symptom that popped up separate from, tremor, stiffness, balance, that are typically associated with Parkinson's, and non-motor symptoms were different among women compared to men as well. Now, this is a smaller study. This is a little over 100 patients, but we found these differences to be quite interesting. Constipation and anxiety were more often seen as non-motor symptoms as opposed to sleep disturbances and cognitive issues noted in men. So those sorts of differences, I think, are real and are out there, and there are bigger studies that are looking at that more carefully. But I think those differences can lead to these gaps where it's not clear from the outset what these symptoms mean, and so having an objective test can be very helpful, especially something that can be done in the office that's quick to do and high sensitivity that can be helpful. We've had DAT scan for some time. It can be subject to interpretation and the facility that is performing them. And for folks, speaking to underserved areas, that can be difficult to get to for patients who are in rural areas to get to. So being able to do this in an office in a rural setting by a primary care doc, and they're really the folks that are seeing these patients. They're really less than 10% of patients are seeing movement disorder docs. We number less than 700 across the country as far as movement disorder specialists, and only 40% of Parkinson's patients are seeing neurologists even. So many of these patients are with their primary care doc. So as many tools as we can provide to all practitioners, not just, specialists, not just neurologists, I think that really can improve these gaps that we're seeing, especially with, as Indu referred to, the explosion, really the pandemic, essentially that we're seeing of Parkinson's in terms of this increased incidence. Again, sort of move that needle as much as we can.
So, where are we in terms of enhancing the clinical toolbox to support the early diagnosis? What tools, innovations are you all most excited about?
So, from my side, the Michael J. Fox Foundation has been crucial in terms of their support of innovative techniques to assist with diagnosis. It is really still, I think, considered primarily a clinical diagnosis. I think we have gotten better. The Parkinson's rating scale has been refined and is more detailed now to include non-motor symptoms. So that I think has helped in terms of capturing folks that maybe otherwise wouldn't be sort of captured, but having biomarkers would be huge. And so the CSF biomarkers made a lot of headlines. There are efforts at imaging biomarkers as well. That scan, as I mentioned, has been out there for some time. And the skin biopsy is what we're studying and is available clinically now. We're seeing 95% sensitivity across the synucleinopathies. So that's Parkinson's, MSA, DLB, and pure autonomic failure, which is considered often prodromal to the other conditions. So with that 95% sensitivity, we're hoping that that can improve gaps in diagnosis even further, potentially. If we're able to catch folks on the prodromal side, multiple studies have been done, like PARS study and such, that have shown that there are multiple prodromal symptoms. I think down the road, potentially blood biomarkers will be available. There are digital biomarkers as well. So these are wearable technologies that can help to define and quantify symptoms further. The Critical Path Institute is in Arizona, where I practice, and they're looking at GEM-PD, which is it's an initiative actually specifically focused on women and using the digital technologies and following them over time. And so if we can look at that sort of technology, even in the prodromal state, can we catch folks even earlier? So I think those are all some really exciting things.
And I think from my perspective, as a clinician, largely, I deal with quite a complex population in the Center of Excellence. I think it's a very clinical diagnosis in my hands still. I think, if you have access to a movement disorder as neurologist, which I agree many people don't have throughout the world, don't have access to even a neurologist in many places. And some of the wait times and even parts of, the developed world can be on the order of sometimes 4 or 5 years just to get into a specialist to get care. So I think if we can, gather data, I think it's definitely helpful. I think giving the message that someone is at risk for getting a disease needs to be given along with something that the patient can do for themselves. Otherwise, I think you've largely given them anxiety about their future with not a lot to do. So I think we have to be careful in having these technologies and giving these sort of counseling that we are giving counseling along with, a sense that this can affect, the psychology of the patient, cause anxiety, unless it's, we're closely following the patient, after that, and we're giving them, tools in which we can guide them to how to, sort of improve their outcome that are useful for them. And so, I think that, the future is bright with all of this. And I think it's very exciting times that we're in, that we hopefully can open access to patients earlier. I think just building disease awareness amongst our primary care colleagues, as well as advanced practice practitioners and whoever's touching the patient, is huge. And I think if somebody's given a possible diagnosis of Parkinson's disease, if they're a young woman, I would still hope that they would be able to see a neurologist and a movement disorder specialist. I think that would be very important, even one time, just to confirm the diagnosis and get them on the right path. And we put in our guidelines, in the paper, reasons to try to see a neurologist would include if you're young, if you're thinking of getting pregnant, if there's a question of your diagnosis, if you can even check in once a year and have somebody bless, the treatment by whoever is local. It's worth the drive, in my opinion, to get to see one of us who, we spend 4 years as a neurologist and then 2 years as just learning the ropes of a Parkinson's specialist. And I think, no matter who you are, I think you're worth, hopefully having some guidance from someone with that expertise. So I think, I think this is data. We have to do studies, and I think it's part of our armamentarium to kind of hopefully moving the needle earlier to getting people appropriately diagnosed and then on the appropriate treatment. And I think, the prodromal arena of potentially, primary prevention would be very exciting, for us to have, a list of risk factors, a way to diagnose and then possibly prevent onset of disease altogether. Many of us are waiting for that day. But, at this moment, people who've had the disease for 5 years for women are being told that they're crazy and that they don't merit, even seeing a specialist at that point. So I think, there's a huge gap between, what our hopes and dreams are and what sort of the reality of everyday practices, even in North America today.
And I think, Indu, you mentioned, as far as sort of community and wellness centers, and I know that's a passion of yours, and seeing that firsthand in Phoenix, where I practice, where we started with this multidisciplinary clinic, PT, OT, speech, and then out of that, a patient saw how much better she was doing with exercise and with these very targeted Parkinson's exercises. But she would go home, and after her, short term, whatever, 8 week physical therapy plan, and then she wasn't really motivated to continue the exercise on her own. And so we had talked about, what is a way that I can just kind of keep moving. And so out of that was born this neuro wellness, and there's two now in the Phoenix area. And with that, that is basically like a gym membership, but it's really specific to patients with neurological conditions. They're primarily Parkinson's patients, but anyone with neurological conditions can join. But what's wonderful is that there are therapists and patients who are familiar with Parkinson's, so that a patient doesn't have to go into, getting that sort of information that's really aimed at wellness, I think is huge. And especially, for if we are going to talk about this prodromal population, that's really what we have right now, right? It is really going to be focused more on wellness. And together with the Parkinson's Movement Disorder Alliance, we started this Proactive Brain Health Alliance, which is an online program really modeled after Dr. Subramanian's work during the pandemic, with all of her webinars focusing on Parkinson's and where things were with research, and what patients can do to improve their health. And so this initiative is really focused on that sort of potentially prodromal population or cohort, so that they can be really proactive as possible with exercise, nutrition, sleep is huge. And so the idea is to really have a place for folks to go that are looking for, how can I be proactive? How can I improve my health, even if it is in a non-medication way? How can I access, community? So hopefully things like that will give patients a place to land, to patients as they proceed through their journey with Parkinson's, whether it's, from the prodromal side, or whether they're 5 to 10 years into their diagnosis and looking for something more. I think that's where everyone, potentially can have a place to land.
Well, we've covered a lot, from the diagnostic challenges, the importance of timely access to a diagnosis with innovations, But real change certainly takes time and vision. So, as we wrap up here today, I'm curious as we step into the future, what is giving you hope and what impact do you want your work to have in the years to come?
The times are quite unique at the moment, and a lot of my work has been in DEI actually, and my hope is that that will continue to be a priority for all of us who are physicians because we see time and time again that there's unique populations of patients. There's niche populations that do very well. If you're a patient who is privileged enough to have access to all care, a wife who drives you in and cooks for you and takes good care of you, I think this is a very treatable disorder for decades to come. If you are don't have those things, if you are the caregiver yourself, you are a young mom, you are not feeling that you are valued as a person enough to come in for your own appointments, that you sometimes put yourself last, as women often do in medicine. Even we tend to take care of everyone else, and then if there's enough time, then we will schedule our own appointment. Where we saw that in our paper that women found tremendous self-worth in being caregivers for others, and if they couldn't fulfill that caregiver role, that they felt badly and self-blame and shame actually. So my hope is that we can sort of hear that patient voice and elevate them. And these patients, I think, are coming forward and fighting for each other, and it's a really beautiful thing to see when women come together and support each other. And I think we're finally in that place where we are feeling empowered enough to really elevate this messaging and to sort of demand that women are included in trials, that women's issues are being studied, and that we need to know. In every study I look at how many women are included, how many people who are non-white are included in the population, and we're hoping that we can move the needle to really focus on populations that haven't been studied for the benefit of all of our patients, because this is such a complex disease that we need to understand the genetics, the toxins, the interplay between all of these things in every unique population to even just serve the patient that may be in front of us. So my hope is that we can really spend the time to get back to the basics in the future of hearing the patient and what their story is. Becoming sort of practitioners that take that story and put the patient in sort of this in the center of the care model, and can really deliver hopefully what they feel is important for them, in terms of what brings them health, what brings them joy and meaning in their lives, and focus our energy towards that rather than doing the same old cookie cutter treatments for everybody that comes in that we've done. I think sometimes the medicine is not in pill or the surgery, even though those do help many symptoms. I think it's sometimes in the human interaction, which we've talked about today. Sometimes it's in the understanding of the non-motor symptoms and the mental health burden, which is actually huge. Many of our patients are depressed, they're anxious, they have tremendous sleep issues, they're apathetic. I mean, these are the things that really affect the quality of life for our patients. And so, if you have a young person battling with those things and they don't know why, if we can help them understand that this is early Parkinson's, and then help them get treatment and see that they're not alone, and destigmatize sort of that sort of issue, I think that can be hugely important. And I think that social support in the community that you've heard about today as well is so important for each of us, even for each other here with Padma. But I think our patients get this diagnosis and they feel very alone, especially if you're a young woman, you don't see other women that are like you who are dealing with this. And that sort of stigma and that isolation can be a huge part of why they don't do well and feel well. And so if we can prevent that from the get-go by offering these resources that we've talked about, offering support and offering peer-to-peer support with other women that look like them, I think that's a huge way to change their outcome.
Absolutely, and I would echo all of what, Indu has mentioned, and especially in terms of what gives me hope is seeing what patients are doing every day, what they're dealing with, and what they're continuing to be inspired to do, to participate in clinical trials, to help the next generation of folks that are going to be dealing with these conditions to, sign up for the brain bank. They decide that, well, I'm not going to need my brain when I'm gone, so I'm going to donate it to science. And I'm hoping that this is going to help, the next generation. And that what a tremendous gift that that patients can give, and that is so inspiring and so hopeful that, despite everything that they're dealing with, despite the disability burden, despite, all of their challenges, that they're still hopeful that, science will come through with more options and even a cure for the next generation. I think that's incredibly inspiring. I'm inspired by people like my friend Indu here who are doing amazing work, looking at ways that we can improve health, not only for our own patients, but, for society at large, for the world at large. What are things that we can do to close those gaps and to help people who are falling through the cracks, because we know that they're out there, and we can do as much as we can in our own clinic, but, how do we help those, beyond our clinic? Inspired by, the people that I work with, the therapists out there, the social workers, all of the folks that are involved in caring for patients. They are truly inspiring, and even the next generation of our mentees and our next generation of clinicians and scientists that are getting into this field, they are showing so much enthusiasm and so much interest and curiosity, and resiliency already. They're showing so much of that. So I think I find that to be inspiring, and I'm hopeful to continue that sort of work. I'm really happy to be, mentoring college students that are interested in, going to PA school, and mentoring, medical students that are doing research, and residents who are interested in movement disorders. And um, we have this wonderful program led by one of my mentors, Jean Hubble, who is a movement disorder specialist, and this is her sort of mission project, passion project, is to develop this program for movement disorders docs to work with the younger generation and to inspire them, hopefully through mentorship, and provide opportunities and education. And so I'm hopeful that I can, continue to participate in that, and help sort of the next generation and learning how best to care for patients, and hopefully we can get to the point of precision medicine and really get to a point of, individualized treatment for patients, as opposed to sort of a cookie cutter approach to patients.
Well, I'll certainly say you all have inspired me. The key message for me here today is that collectively, when we remain resilient, curious, step away from some of those cookie cutter approaches and listen to our patients, change can and certainly does happen with all these exciting innovations that you've shared with us today. So, as we wrap up, thank you both for sharing your stories, your expertise, vision. I think the conversation is clear. Changing the Parkinson's narrative, especially for women, requires not just better science, but deeper empathy, stronger systems, and courageous leadership. And to our listeners, whether you're a clinician, researcher, advocate, or just starting out your career, your voice matters in shaping a more inclusive and responsive future for movement disorders. So we hope this conversation has sparked some new ideas, inspired action, and reminds you that change is possible. So until next time, thank you for tuning in to hear from her.
Thanks, Sarah.
Thank you.
To our listeners around the world, thanks for joining us today. Tune in as we continue our journey to amplify the voices of women leaders in healthcare. Hear From Her is brought to you by Medscape Education. Please subscribe to Hear From Her on your preferred podcast channel and follow us on LinkedIn. Until next time, remember to lift as you rise.